Hello, everybody. Welcome to the ADAA webinar, Coping with Panic Attacks. I'm Dr. Suma Chand. I'm an associate professor in the Department of Neurology and Psychiatry. I'm a clinical psychologist specializing in cognitive behavioral therapy at St. Louis University School of Medicine. I'm a member of the ADAA Public Education Committee, which has produced this series of monthly webinars. I'm your host for the webinar today, so I'll just run you through some of the technical aspects of this webinar. On the right side of your screen, you should see a Q&A panel. There's a little field at the bottom of that panel, and when you click in it, you can type in a question. Then either hit your Enter key or click the icon. Now, you should be listening to this through your computer speakers. You do not need a telephone connection. If you've dialed in, please hang up and turn up your computer speakers. You can ask questions at any time. Rather, you can type in a question at any time, and we'll try to get to as many as possible. Other participants cannot see your questions. Now, we may not have time to get to your individual questions, so we apologize if that is the case. We are recording this webinar to make it available on the ADAA website at a later date, so you can always run through it again if you wish to. Today, we'll be hearing from Dr. Jenny Yip. She's the Executive Director of the Renewed Freedom Center for Rapid Anxiety Relief in Los Angeles, California. She's a Clinical Assistant Professor of Psychiatry at USC Keck School of Medicine. Dr. Yip will review the specifics of panic attacks, what they are, why they occur, who gets them, and address specific treatment strategies to decrease their occurrence. Now, before we begin the presentation, I'd like to tell you about the Anxiety and Depression Association of America. It was started in 1979, and today it is a leading nonprofit organization dedicated to increasing awareness and education about anxiety disorders, depression, obsessive-compulsive disorder, post-traumatic stress disorder, and related illnesses. ADAA's mission is to improve diagnosis and promote the prevention, treatment, and cure of these disorders through education, practice, and research. ADAA fights to end stigma by promoting the message that they are real, they are serious, and treatable. Please visit the ADAA website, that's www.adaa.org, which includes Find a Therapist, which is a searchable database of treatment providers, as well as free educational information and resources, self-tests, self-help groups, clinical trials, and a lot more. You can support ADAA's efforts, such as this webinar series, by making a charitable contribution on the ADAA website. Now remember, you can type a question at any time. I'm going to turn it over to Dr. Yip. Dr. Jenny, you're on.
Hi, yes. Thank you for having me, Dr. Chand. So today what we're going to be talking about is panic attacks. And I'm sure many of us, we've either experienced it ourselves or have noticed, observed other people experiencing it. So what I like to do is talk about what panic attacks are, because panic attacks are not the same as a panic disorder. So first of all, a panic attack is something that is experienced very, very intensely. It's a surge of your body's fight-or-flight response that occurs within a short period of time, and it creates a lot of discomfort and terror. It usually occurs suddenly, and there is often an impending fear of doom. Usually lasts no more than 30 minutes, although when you are having a panic attack, it might feel like a lifetime. Most people report that they fear dying when they're having a panic attack, or they feel like they're going crazy, they're losing control, or they're losing touch of reality, and they are losing control of their emotions and behaviors. And when you do have a panic attack, the urge to escape from this intense discomfort is immense. And that's what people usually do. They attempt to escape. So why do panic attacks occur? Well, to be honest, panic attacks is a part of your natural survival instinct. It happens when you're experiencing your body's fight-or-flight alarm that is triggering you to either fight or run. And I'm going to talk a little bit more about that in a second. However, panic attacks also occur because we often misattribute the bodily sensations that we experience. So for example, if your heart is pumping very fast, you might feel like your heart's jumping out of your body. And you attribute that to, oh no, I'm having a panic attack, or even worse, oh no, I'm having a heart attack. A lot of people also feel that they're having an asthma attack when they're having a panic attack, so they cannot breathe or they're feeling like they're choking. So the reality is that a lot of these bodily sensations don't necessarily mean that your body is in danger. Yet those of us who have experienced panic attacks have attributed those bodily sensations to meaning that something bad is happening to our bodies. There's also anticipatory fear of the unknown. So, for example, people who have medical or dental phobia fears, where they are constantly worried about what might happen if they go in to see a doctor for a procedure, or what might happen if they go see a dentist. And it's the unknown that usually drives your brain, drives your mind to ruminate on the worst possible consequence. And what ends up happening is one negative thought will trigger another, and before you know it, you've got into a tornado of catastrophic consequences that might potentially occur to this unknown situation. So you're expecting the worst outcome when it is any unfamiliar situation. So let me talk about the fight-or-flight alarm, which is what's actually happening when you're experiencing a panic attack. So this is our classic example of the fight-or-flight alarm. If you're faced with a saber-tooth, your body must react in order for you to survive. Your options are either to run or to fight. And I know that there is the freeze response, though if you were to freeze during a saber-tooth appearance, you probably won't survive that. So the fight or flight response it occurs in order to equip your body to survive any potential danger. So for example, your heart rate starts to go up. Your heart starts to pump faster. And you have to imagine that your heart is your body's natural motor. And the purpose of the heart is to pump blood carrying oxygen throughout your body so that the organs have the energy it needs during a true fight or flight experience. If you are running or fighting, you need your motor to be running fast in order to fight or run. Your breathing intensifies. And your breathing intensifies because you're bringing in oxygen into your body's system, which is the fuel, the natural fuel that your organs need, especially to your brain and to your muscles. Your ability, your GI tract, that's your gastrointestinal tract, shuts down or slows down because energy is being diverted to your large muscle groups to help you to fight or run. Your ability for cognitive reasoning actually decreases because when you are faced with a true danger, you really don't have time to think, oh, should I run this way or that way? Will it be better to use this tool, this weapon to fight, or that weapon? You have to respond on instinct, and therefore your body's, your mind's, your brain's natural ability for cognitive reasoning actually goes down. So if anyone has ever told you to just think about it while you're having a panic attack, you can always say, you know, I heard it from a webinar and that's not really possible. Now, what if you saw this instead? You saw this kitty cat. Well, if you actually saw this kitty cat, your body's natural fight-or-flight alarm would not react. The reason why is because you're not perceiving danger. And because you're not perceiving danger, you don't find it necessary to either fight or run from this harmless kitty cat. Though what happens for a person experiencing panic is that this person is constantly seeing kitty cats as saber-tooths. So what's happening cognitively is that we are misappraising harmless situations that are really not threatening as dangerous. So what this tells you is that it's important for us to be able to distinguish the difference between a false alarm as the kitty cat and a real threat as if there was truly a saber-tooth in front of you. Now, how do panic attacks worsen? Because for those of us who's experienced panic attacks, it actually gets worse and worse and worse unless you seek treatment. And how does it get worse? Well, this is basically your fear cycle. This is the vicious cycle of anxiety. And on the top, you have your feared trigger. This can be anything. This can be a thought or a specific situation, such as giving a speech, or a bodily felt sensation, such as your heart palpitating. And whenever you experience this specific trigger, you're feeling discomfort, distress. I'm sorry, this is supposed, there's an error on this cycle. So where it says anxiety and panic, that needs to be moved over to the arrow on the top right corner. And whenever you experience this trigger, this feared trigger, you automatically experience anxiety, distress, discomfort, and naturally so, right? Because if you see a saber-tooth in front of you, well, of course you're going to go into panic mode. Of course your body's fight or flight is going to trigger. And when we're experiencing this intense discomfort, we naturally want to escape this discomfort. And thus, we escape by either avoiding the trigger or avoiding the situations that lead to this trigger, or we distract ourselves, or sometimes we might even seek reassurance from our friends, loved ones, coworkers, or just to make sure that this is safe. Now, the problem with this escape behavior is that it brings you relief, though only temporarily, right? So if I'm feeling uncomfortable, I'm going to escape and, I feel better. Problem is that feeling better doesn't last forever. And before you know it, you're going to run into a thought, a situation, or a sensation that's going to trigger the panic attack again. And when you experience a panic attack again, you're going to naturally want to escape. Though, again, the problem with escape is that it gives you the relief, which actually reinforces this whole cycle. And so the problem here isn't the feared trigger, because we have no control over our surroundings. We have no control over what our body experiences. We have no control over what type of thoughts we have. We have no control over the discomfort that we experience as well. So anxiety and panic is also not the direct problem. The direct problem here is actually the relief that we get when we escape, because we have direct control over escaping. That is the area that we're going to target when it comes to treatment. So what are some experiences of panic attacks? Well, panic attacks can feel like your heart is racing, skipping. You can feel chest pains or pressure. A lot of people experience dizziness, lightheadedness, nausea, difficulty breathing, feeling like you're choking, or a lump in your throat. You're trembling or shaking or sweaty, clammy hands. A lot of people have stomach problems or sudden diarrhea. Again, that's because of the GI tract, your gastrointestinal tract, shutting down during a fight or flight response. Besides, can you imagine if you're running or fighting from the saber-tooth and all of a sudden, ooh, I need to go to the bathroom, or ooh, you know, I need to eliminate right now? You wouldn't be a very equipped person for survival if your body responded in those ways. A lot of people feel tingly or numbness in their body parts, and they feel flushes or chills. Most importantly, many people with panic attacks fear they're losing control, and they fear doing something embarrassing. And the sensation of panic can be very, very terrorizing, like something unimaginably horrible is about to happen, and you're helpless to prevent it. So what is the difference between a panic attack versus panic disorder? Well, as I've said, a panic attack can last for several minutes to about 30 minutes long, and is one of the most distressing conditions anyone can experience. Most people who have one panic attack will have more panic attacks. Now, when you have repeated sudden attacks without any specific triggers, so it's not because you're giving a speech and you're having a panic attack. It's not because you see a saber-tooth and you're having a panic attack. It's not because you're going to the dentist and therefore you're having a panic attack. When there aren't any specific triggers and you feel severe anxiety about having future random attacks, then you are likely to have panic disorder. So panic disorder really is a fear of the fear. You're fearing your internal bodily sensations going haywire, and you don't know why. You don't know why it's occurring. You don't know what it's occurring because of. It just seems unexpected, sudden, and without reason. So when you are having panic attacks to a known reason, such as a dentist, giving a speech, going to school, then you're said to have phobias. And I looked up phobias, and there are thousands on thousands of different phobias. And I selected a few of the more common phobias, such as fear of open spaces and crowds and leaving a safe place. We call that agoraphobia. Many people with panic attacks also have agoraphobia. And then there is acrophobia, fear of heights, algophobia, fear of pain, aviophobia, fear of flying. I mean, I can go on. And the truth is anything you can be afraid of. Though, again, the difference between a panic attack and panic disorder is when it's a panic attack and when there's a known cause for the attack, it's more of a phobia. And when there is an unknown cause, so the attack occurs unexpectedly, then it leans more towards panic disorder. So here are some specific external triggers to phobic fears, such as these places, hospitals, medical facilities, schools, crowded areas, planes, tall buildings, elevators. And then people can have phobic reactions to specific people, such as doctors, dentists, teachers, even friends and family. You can also have panic attacks to specific situations, such as giving blood, getting injections, any medical or dental procedures, a social event, even having meals in public, speaking in public or performing in public, being in business meetings. So as you can see, there are many situations that can trigger panic attacks. Now, that is different than having a panic attack with the fear of your internal sensations. And this, when you have a fear of your internal sensations, this is where panic disorder starts. And panic disorder is going to be a lot more difficult to address than panic attacks for phobias. The reason why being is because there is a specific tangible object or situation or people where the attacks are occurring that can be controlled. Whereas for panic disorder, it's the internal bodily sensations which are more difficult to manipulate. So some internal bodily sensations include tactile cues, such as feeling your heartbeat, shortness of breath, feeling hot or cold, nausea, lightheadedness, gagging or choking. And then there are auditory cues, such as hearing your heartbeats, hearing specific sounds. Then there are olfactory cues, such as the smell of plastic, like when you're at a dentist, taste of blood, certain meats. Now, who experiences panic attacks? Well, about 2 to 3% of adults and adolescents experience panic disorder. And overall, 11.2% of adults experience panic attacks. Now, of this 11.2% of adults, 7% of them, of adults and children, experience social anxiety. 7 to 9% experience specific phobias. And about 1.7% of adults and adolescents experience agoraphobia, which is basically fearing not being in a safe place or being in crowds or leaving a place where you feel safe, such as your home. In addition, about 90.4% of people with panic disorder also met criteria for at least one other psychiatric diagnosis, social phobia being the most common, generalized anxiety being the second, and specific phobia and obsessive-compulsive disorder. So as you can see from these statistics, there are quite a lot of people experiencing panic attacks. And even those people who experience panic disorder usually doesn't just come alone. It often comes with other psychiatric diagnosis. Panic attacks, of course, come with a whole host of consequences. The urge to escape from the place where the attack begins will trigger future panic attacks. So if you had a panic attack at a basketball game, then the likelihood of you having another panic attack at that basketball game is more likely than not. And the reason why is because you're constantly going to be hyper-aware and hyper-focused, especially if you're worried about having future attacks, about having another attack at a basketball game because that's where you had one the last time. You're going to avoid places, people, objects, situations, and it will often lead to agoraphobia. Many people with panic attacks end up locking themselves at home because that's where they feel safe. They feel it's unsafe to leave their safety net where their help won't be available or medical facilities won't be available, or they will just be stranded without anyone to help them, or they will be in public and having a panic attack in public would be embarrassing and they're afraid to appear embarrassed. A lot of people with chest pains or shortness of breath during a panic attack will seek aid from a hospital emergency room. And many of my colleagues who are medical physicians will say that every single night they will have at least 4 to 5 people who come into the ER claiming that they're having a heart attack and they're actually having panic attacks. People with medical dental phobias will avoid getting certain procedures that is necessary for their health, and not obtaining those preventative care will increase the health hazards. So as you can see, there are many different consequences to having panic attacks. Then there are psychosocial consequences, where having panic attacks, it can disrupt relationships and social isolation because you're afraid of having a panic attack out in public or when you're socializing with your friends, and therefore you avoid it altogether. Your ability to function and self-care is decreased. There's more of a sense of emotional embarrassment. Obviously, from the decreased independence, a lot of people with panic attacks will repeatedly cancel appointments and plans, whether it's appointments with professionally or personally. And refusing immunizations or blood testing can limit employment, obtaining health insurance, travel, education, and even marriage in some places. And there's definitely the increased long-term healthcare cost for panic attacks. So what in the world do we do with panic attacks? Well, the evidence-based treatment is cognitive behavior therapy. What does this mean? What cognitive behavior therapy is that we target behaviors that are going to be healthy. We help you think in ways that will represent reality more accurately rather than catastrophically or distortedly, like seeing the saber-tooth when you actually saw a kitty cat. So in CBT, we know that you cannot control your thoughts. You might be able to avoid thinking about something, though not for very long, because anyone who's ever tried to avoid not thinking of a fear will think more of the fear. So we know that you have no direct control over your thoughts. You have no direct control over your feelings or your emotions. Again, we can try to avoid emotions. We can try to suppress them, though we have no direct control over emotions. If I say I want you to be ecstatically joyful right now, the only way you can be ecstatically joyful is to think of a situation or a time where you were joyful. I can't tell you to be angry right now, and you can automatically, with the snap of a finger, be angry. You have to first think of a situation that you were angry about in order to experience anger. So we know that you cannot control your feelings because your feelings are triggered from thoughts. And we have no direct control over your thoughts. You can only control your reactions to the thoughts that you have. So for example, it is not possible to control that you do not fear the saber-toothed tiger, the thought of the saber-toothed tiger. Though what you can do is control your reaction to that thought. So if I ask you to think of whatever it is that you fear, now you can either respond with having a panic attack, or you can respond differently by attributing that distorted saber-tooth back into a kitty cat. So this is what CBT teaches you to do. It teaches you how to change, how to shift your thinking so that it reflects reality more accurately, number one. And number two, how you can directly manipulate your actions, your behaviors, so that the fears decrease. So, some specific strategies to eliminate panic attacks. Well, you must avoid avoiding. And the reason why is if you avoid, you're never going to unlearn the distorted reaction that you have. You're never going to unlearn that this kitty cat actually is harmless. You will continuously fear this kitty cat even though it is really harmless. So you have to avoid avoiding, because when you avoid, it inhibits the correction of mistaken perceptions and distorted beliefs. Second of all, you have to engage in interoceptive exposures, and I'll go more into details about what interoceptive exposures are. Just briefly, exposures in general increases your comfort zone by learning to tolerate the physical discomforts. And we all know that anything that we fear, in order to reduce the fear, we have to learn to confront it. So if we fear spiders, well, avoiding spiders isn't going to teach you that the spider is actually harmless. It's actually only going to increase your fear and give you more credence to keep avoiding this fear. In fact, if you're afraid of spiders, what you have to do is slowly engage with spiders, slowly look at spiders, slowly get close to spiders, and see and learn that the spiders actually are harmless. And once you're able to do that, then you are changing your belief system. So this thing that you fear is no longer threatening. So that is what in vivo and imaginal exposures are, confronting the feared places, objects, people, situations. Then we have to correct thoughts, okay? So this is what I was talking about earlier. In order to change your faulty belief systems of catastrophe, you have to correct the thought that this saber-tooth actually is a kitty cat. So it disconnects the learned alarm reactions to your bodily sensations, okay? We also need to identify the misperceptions of false alarms versus the real threats. So for example, when your body is feeling tingly, it's feeling hot and cold, or you're breathing heavily, you're feeling that tightness in your chest, well, that might not be because you're having a heart attack. In fact, more likely than not, it's not because you're having a heart attack. So we want to be able to identify correctly what are the felt experiences that we're having, rather than constantly attributing them to panic attacks or heart attacks or something harmful that is occurring to your body. And in order to do that, what I suggest to a lot of my patients is to experiment, right? Is to test out your expectations. Okay, well, I'm afraid of the spider. And I know that if I touch the spider, I will get a bite, and it will be poisonous, and I'm going to die. Well, how likely will you to maybe stand next to it? Will standing next to the spider cause you to die? Test it out, right? So testing your expectations, testing your belief system in order to identify whether your beliefs are correct or inaccurate. So I want to talk about interoceptive exposures, because interoceptive exposures is targets panic attacks directly. And remember, a panic disorder is when you fear something wrong happening with your body, right? You're fearing that that the chest pains might actually be a heart attack. You're fearing that your difficulty breathing might lead you to suffocate. So a panic disorder is when you're fearing your internal bodily sensations. And you're fearing it because there's no explanation of why they're occurring. Though, oftentimes there is an explanation, and you're not thinking of it. So, I've had many patients where they would avoid even walking up a flight of stairs because they're afraid of feeling their heartbeat. they're afraid of feeling their body sweat, or they're afraid of feeling their body being warm. And that fear in itself might trigger a panic attack. So for interoceptive exposures, what it means is that we are going to expose you to your internal bodily sensations that you fear, so that you learn that the fight-or-flight response that you get is actually unrelated to a panic attack. That just because your body experiences your fight-or-flight trigger, your fight-or-flight alarm reaction, does not necessarily mean that something bad is happening, right? Can you all just imagine if you were just, if you didn't feel anything from your body? I mean, would you really be living? So if you are exercising, of course you're going to feel your heart palpitating. Of course you're going to feel a shortness of breath. Of course you're going to feel sweaty, hot, maybe even lightheadedness and dizziness if you haven't exercised in a while. Though that doesn't mean something bad is happening with you. So in order to learn that, what we actually have to do is put patients in situations, of course, in a controlled setting, in a safe setting, where you can experience your elevated heart rate, feeling hot, sweaty, rapid breathing, and not automatically attribute it to something wrong happening, something bad happening. It teaches you that your internal bodily symptoms need not develop into a full-blown panic attack. So we can, for example, have you run up and down stairs to mimic the sensation of your heart palpitating. We can have you spinning in circles to mimic the sensation of dizziness and nausea. We can have you hold your breath to mimic the sensation of not getting enough air in your lungs. And of course, these are all done within structured, set times where we're measuring the length of time that you're engaging in these exercises and the intensity of the discomfort that you're experiencing. And after the exercises, whether you're running up and down the stairs or holding your breath or spinning in a circle, just by the passing of time, your body's fight-or-flight response has to come back to neutral. So it is not possible for your body to stay at a heightened level of discomfort, a heightened level of fight-or-flight arousal for a prolonged period of time. Your body simply cannot sustain that. After a period, usually about 60 to 90 minutes, your body has to naturally come back down to baseline, and your body has to recharge. So it's important for you to learn that, and therefore you learn that by doing nothing, not even escaping or avoiding the discomfort, your body naturally will come back down to baseline. And in fact, by doing that, you are unlearning that you're basically relearning, actually, that the saber-tooth really is a kitty cat rather than the other way around. Because you're confronting the fear and you're experiencing that this specific trigger actually is not so threatening. Nothing bad actually happened to you. You didn't die. You didn't have a heart attack. You didn't suffocate. And therefore, this fear is not reasonable. It's not rational. And when you can learn that, then what it does is actually diminishes the fear itself because you're confronting it and you're learning that it's not threatening.
The conference is no longer in lecture mode.
Hello? So I'm going to keep going. So what are some specific interoceptive exposure instructions? Well, you have your cardiovascular exercise, right? So whether it's running up and down the stairs or doing jumping jacks, sometimes we have people inhale carbon dioxide, spinning in the chair, shaking your head from side to side, running in place, putting your head between your legs for 30 seconds, then quickly lifting in order to mimic the sensation of lightheadedness and dizziness. And after each exercise, what we teach patients is to learn to apply mindfulness training, which basically means that you're going to focus on your body's internal sensations rather than distract. Because what a lot of people end up doing is they end up distracting. So they might run up and down the stairs, though mentally they're distracting themselves from the felt sensations because it's uncomfortable for them. So we want you to be mindfully aware of your felt sensations rather than distracting and perhaps mentally escaping to Disneyland. And by being mindful about it, it actually increases your empowerment that by doing nothing, by actually focusing on the sensation, that you are controlling the panic symptoms, okay? So what this also teaches you is that you can induce the sensation on your own. And you can induce the sensation on your own and learn to manipulate it on your own. And therefore, when you do have unexpected panic attacks, you already have the skills of what to do with them. It's not going to feel like it's the unknown. You're in familiar territory because you've experienced it time and time and time again in a controlled setting. So I tell patients once they've practiced and practiced and practiced these interoceptive exposure exercises, when a panic attack actually occurs and it's unexpected, then this is your opportunity to take control over the panic symptoms by engaging in whichever exercise that mimic the same sensation that you're currently experiencing. Because you've done it many times in controlled settings, this is your opportunity to practice what you've learned from the controlled setting to the real situation. So some of the results, and I'll quickly move through this, is that you understand what a panic attack really is. It's not really an unexpected, uncontrollable panic attack. It's really just your body's fight or flight experience, fight or flight reaction because you've perceived danger, perhaps misperceived danger. And it teaches you that you can actually control your body's fight or flight sensations. You can control your breathing. You can control your heart rate. You can control that dizziness. And when you are engaged in these exposures, it allows you to decrease that learned alarm reactions. So when you do experience a panic attack, or actually when you do experience, when you do see a spider, you no longer need to respond with an alarm reaction because you've confronted it, you've experienced it, and it actually didn't do harm. So it changes your belief system. It changes your catastrophic thinking, and it changes your belief system about what your body's capable of. So it will increase your confidence that you can tolerate more than what you previously believed that you can. So what is the difference between exposures and escape? Well, if you look at this diagram, the pink line is the exposure response. The blue line is the escape response. So the escape response is basically whenever you experience or when you come into a situation that ordinarily would trigger panic, you will experience a heightened fight or flight response. And within 30 to 90 minutes, that discomfort will go down, naturally so. Actually, when you escape, your discomfort will go down. But that doesn't mean it's over, because the opportunity to have another panic attack will always be there. It's not possible to control our environmental settings. It's not possible to control what type of thoughts we have. So therefore, the next time you have a trigger, you're going to experience the intense discomfort, the intense fight or flight, and then after you escape or you reassure yourself, you're going to experience relief again. The problem with this blue line is that it's constant and it's chronic. It keeps bringing your body, driving your body up and down, up and down, up and down. And most people with panic attacks and chronic panic attacks will tell you that it causes them to experience fatigue. It really drains them of energy. And no wonder if your body is constantly experiencing heightened fight or flight reactions. Now, whereas the pink line is the exposure reaction, the exposure response, where if you experience, we're going to purposely experience the discomfort, okay, whether it be spinning in circles, to experience your internal discomforts, or facing a spider for your external discomforts. And by not escaping, by not doing anything, naturally so, your discomfort level has to come down on its own within 60 to 90 minutes, okay? And what you'll eventually see is this pattern, that eventually the discomfort level will be shortened in terms of intensity, as well as shortened in terms of duration. So each time you engage in an exposure exercise, the discomfort will be less and less and less until the point where you're not going to experience the discomfort at all. Okay? Whereas if you look at the blue line, it just continues on and on and on and on. So what else can you do to maintain your functioning? Well, after you've done your exposures, after you've gone through exposure treatment, it is very important to continue to keep up with your life. So I want you to continue exercising. I want you to keep up with the mindfulness training and the meditations. Be engaged socially, because that allows you to be outside of your the space where you would usually hide out and ruminate and think about all of the fears. Group support can be very, very useful. And you want to continue your exposure. So just because you've gone through exposure therapy doesn't necessarily mean that you're done. You want to keep up the exposures in order to increase comfort zones, in order to decrease fears and other avoidances, and especially agoraphobia. And this helps to increase your self-confidence as well as your ability to function on a daily basis. So whether it be continued exposure to spiders, or maybe now your fear has moved on to crickets, whatever it is that you're fearing, you must continue the exposures in order to continue learning that the saber-tooth is really just a kitty cat, of course, when it actually is. Okay? All right. That is all I have. Dr. Sean, are you still there?
Yes, can you hear me?
Yes.
Okay. We have a couple of questions. There is a question here by one of our attendees. He says, I was given Ativan to take every day to stop attacks. Is this a good idea? I feel I'm taking too much Ativan.
Well, the problem with benzodiazepines, and this includes Ativan, Valium, is that it doesn't allow you to experience the discomfort. It actually is that quick escape for your body. And the problem with that is that you will continue to rely on the Ativan, right? And Ativan, as well as other benzos, can be quite addictive. So most people, they will start with a certain dose, and they will need more and need more and need more. So what I actually do with patients is that I teach them interoceptive exposure skills first, and I teach them mindfulness training skills first. And once they really get a hang of it and they can utilize it to control their panic attacks, then we slowly decrease the benzos, of course working with a psychiatrist that can manage the medication. So it's really important to make sure that you don't just go off of benzodiazepines on your own, because that can be very harmful and detrimental to your health. So it's important, if you are taking benzos, to consult with your psychiatrist and find a therapist who knows how to treat panic attacks, panic disorder. And together, the psychiatrist and your therapist can collaborate to help you to learn the tools that you need, learn the CBT tools, and then eventually reduce the use of benzos. And if anyone is looking for therapists, you can go on the ADAA.org website, and there is the option to find a therapist and in your local area, and you can narrow your search by the type of disorders that they treat, the mental health conditions that they treat.
I have another question here. Somebody has asked, is it normal to experience panic attacks while sleeping?
Well, there is there's a percentage of people who experience panic attacks upon waking from sleep. So I believe there's about 25% of people who naturally experiences panic disorder, and this small group of people have the tendency to also experience a panic attack upon waking from sleep. Though, if you're having a panic attack while you're asleep, you might actually be having a nightmare or a night terror rather than a true panic attack.
Now, somebody has asked, do you recommend any CBT programs online?
There is a lot of self-help books out there. I'm not familiar with specific online CBT programs. It really depends on how severe your condition is. If you have never, ever done CBT before, and your condition is quite severe where it's limiting your activities, limiting your ability to function, limiting your ability for self-care, then I would highly recommend seeking a professional for this. On the other hand, if you're not really having panic attacks, if you had one panic attack 10 years ago and you haven't had one since, then it doesn't hurt to try this program. Of course, if your symptoms begin to worsen and becomes more severe, and your self-help book isn't helping or the online program isn't helping, then it's really important to seek a professional immediately. And again, the professional that you want to seek is not just any mental health professional. It's someone who has specific training in cognitive behavior therapy specifically for panic attacks, anxiety, phobias, panic disorders. So just because someone has experience using cognitive behavior therapy, just because a clinician knows cognitive behavior therapy does not mean that professional knows how to use cognitive behavior therapy for these specific anxiety disorders.
Somebody has asked, what about panic attacks and those suffering with PTSD?
Well, panic attacks do occur for people suffering from PTSD. So just like panic attacks occur for people with social anxiety, just like people with specific phobias, and the evidence-based treatment for people with PTSD is still cognitive behavior therapy, specifically prolonged exposures.
Somebody wants to know, is insomnia related to panic attacks or panic disorder?
I'm sorry, what is the question?
Whether insomnia is related to panic attacks or panic disorder.
Is insomnia related to panic attacks or panic disorder? Well, there are many people when they are feeling anxious. Remember again, when you're feeling anxious, it is your body's natural fight-or-flight response at work, right? So your feeling anxiety isn't necessarily a bad thing. It's your body's natural need for survival. What is unhealthy is when you're feeling anxious when there's not a genuine reason to experience anxiety, to experience worry, to be concerned, to experience fear. And therefore, this is where your mind will start to ruminate on the worst possible consequences. And for many people, sleep, your bedtime is the time when your mind will naturally go to those awful places. So yes, insomnia can be related to panic attacks, panic disorder, though you want to be careful though. Are you having panic attacks right before you're going to sleep? Or is it that you're worrying about having panic attacks when you're trying to fall asleep? Or your mind is going to those awful places during that time?
Right. Another person has asked, is DBT effective for panic attacks?
DBT, dialectical behavior therapy. DBT is a form of cognitive behavior therapy that is useful to address impulsive type of disorders and emotional disorders. However, the evidence-based treatment for panic attacks is exposure therapy, and in particular, interoceptive exposures for panic disorders.
We have time for maybe one question.
Okay.
My mother has been on anti-anxiety medicine for 30 years. Is it possible for her to eventually get off medication completely?
You know, every individual is going to be different. Having been on anti-anxiety medication for 30 years is a long time, and your brain chemistry changes with the use of any psychotropic medications. And with anti-anxiety medications, I don't know exactly what class. There are many different classes of anti-anxiety medications. What I would suggest is to seek a professional who is trained in treating anxiety disorders with CBT, such as phobias and panic attacks, panic disorders, and have your first of all, have your mother learn the tools, learn the cognitive behavioral tools. And then once she learns those tools, then work with the psychiatrist to start bringing down that medication if that is what your therapist would suggest at that point in time.
All right, I think we are reaching the end. I don't think there's any more time for any more questions. So I apologize to a few people whose questions have not been answered. The webinar, the slides will be available on the website, so you can always have a look at it again. So thank you very much, Dr. Yip, for this excellent presentation.
Thank
you. Thank all of you for attending this webinar. Please let others know about the series and consider making a contribution to ADAA. Thank you, everybody, and have a good night.
If anyone has questions, if anyone have further questions for me, they can go on to the renewedfreedomcenter.com website and contact me directly there. Thank you so much for having me.
All right. Thank you, and good night.
Good night.